Okay, good morning everyone, thank you for being here. I want to cover two areas and I might focus my first area with the HSE because I want to stay on the issue of devolution and what it's really going to look like, and I'm very heartened to hear that we'll have a kind of a detailed document at the beginning of next year to review. But in preparation for the meeting, I've kind of been going through, you know, the operational organisation of the HSE, and I'm trying to understand what that devolution will look like in real life. So I suppose for you, Mr. Mulvaney, I mean, you've talked today a little bit about national consistency versus a large degree of autonomy. What aspects of your role will be devolved?
If you think about it, my role would, and the people in the HSE Centre would be less involved in the detailed operational management of week to week, day to day, month to month. How are things being done? We'll be involved in less decisions about inputs, how many staff should go with what development, and
okay. So you know, you have a job description with a. So what functions of your job description are being devolved?
And when you say
staff management. Like, could you outline exactly what areas will be devolved for you? I can't outline
exactly that, but if you think about it, I don't today currently anyway manage all of the staff in every part of the HSE. It's done through delegation and through whatever.
Let me, because in looking at this, let's say there's, depending on how you count it, it's between 8 and 10 major operational sectors within your organisational program. Kind of organogram that you have on your website, and I'm trying to get a sense of what that will look like, because obviously there was a major restructuring in 2017, and so we have the luxury, I suppose, of those jobs being fairly well set out at that time. So let's take the Chief Operations Officer, who in 2017 is responsible for service delivery, acute hospitals, community care, national ambulance services, primary care reimbursement services and special delivery units. What of that role will be devolved?
So if you look at it today, Deputy, the reporting into that Chief Operating Officer, there are 9 community healthcare organisations and 6/7 hospital groups, depending on how you count Children's Health Ireland.
But that sits at a level underneath that role.
The RHAs
based on your organisational plan.
The RHAs aren't going to be grafted on top of that. The RHAs will replace that. And a structure
so
below them.
Can you outline how the Chief Operations Officer's job description is going to change?
I can't tell you in detail that, because that's the work we're currently involved in. But what I can say, as I've
sorry now, Mr. Mulvaney, if we're going to see that, if we're going to see that at the beginning of next year, which is in 30 days' time, basically, surely you must have a sense of how those roles are going to change, because that's, as the previous deputy have said, that's major management change.
Absolutely, Deputy, and I'm trying to give you a sense of that.
Okay.
So, at the moment, the Chief Operations Officer is involved in a large amount of detailed implementation discussions, detailed oversight discussions. So, for example, when we implement a new national ICT project, that's often driven centrally and nationally, and what we're getting quite close to getting clear on is, while the genesis of large programmes of work such as ICT projects will still have to be done, have a central aspect to it, and will still collaborate with what will be the RHAs around what are the objectives. The actual implementation, the delivery, the management of that, the making of decisions within a defined resource and a set of objectives.
But what you're describing is central decision making resides with that role.
No, I'm not, Deputy. That's a misunderstanding.
Well, sorry, that's what I've heard from you just now.
I don't believe you have, but just to say.
Okay, well, let's take another role, the HSCP clinical leadership representation, the central role. That's currently being currently being advertised. Is that correct?
Yeah, that's a specific national office for national surveillance. Maybe
okay. No, that's fair enough. But that was also put in place in 2017. Could you describe to me, since we're looking at this huge organisational restructuring, what would be the difference in that role when it was advertised in 2017 as opposed to when it's advertised in 2022? Even though it's a central role, you would expect to see it change because we are devolving our health service.
Maybe one of my colleagues may want to.
Yeah, maybe, Deputy, if I can take your question and just reflecting on your first question around the role of Chief Operating Officer. I mean, a big change will be that the operational components of the HSE will be with RHAs. So the ongoing existence of an operational component centrally will be very, very limited. There are some services that run nationally that will need to continue to run.
Can you speak to the HSCP role? So somebody has just written that job description and it was also set out in 2017. What's the difference?
Yeah, no, directly I can't right now, so I don't want to mislead you on that. But I think, just to go back...
There doesn't seem to, I have the two job descriptions in front of me. There doesn't seem to be any
Chief
difference.
Clinical Officer might comment on that.
Sorry, this is the health and social care professional lead you're referring to.
It's HSCP, Clinical Leadership Representation, so yes.
So what that role does is facilitate training and education. It doesn't have, sorry, can I just finish the question, Deputy? It's not an operational lead, this person. This person...
That's not my question. My question is, in a major organisational restructuring, even senior roles, you would expect them, the job description in 2017 to be different from 2022. Is there any difference?
That role, as my colleague was saying, the major difference to RHA is they become operationally responsible. There are some central roles that are educational, facilitate educational and training.
Again, what you're describing to me is the central decision making hasn't changed since 2017.
No, I'm describing to you a role that is not in the operational line, Deputy. It's a line that fosters and develops training and development for health and social care professionals.
Okay, I want to move on to my second part before I run out of time. At the recent budgetary oversight, and this is for the department, I suppose, more than anyone, at recent budgetary oversight committee, we discussed the implementation of Sláintecare with IFAC, with the Irish Fiscal Advisory Council. And obviously, the Irish Fiscal Advisory Council is tasked with, I believe on their website it says, assess and endorse the government's official economic forecast, assess budgetary forecasts, assess the government's fiscal stance and monitor fiscal rules. So things like major restructuring of our healthcare system, I mean, like it's one of our biggest costs in the state, would be kind of central to their work. So we were discussing it, and I want to read from the transcript of that discussion a little bit. There's incredibly, and this is from IFAC, from the person, Mr. Sebastian Barnes representing IFAC. There is incredibly limited information on, we were talking about Sláintecare, and this is a big problem. And then I'm asking them, it's very concerning, is it? And we look, and then Dr. Eddie Casey comes back and says, we looked at this in an analytical note before, and the questions we have of Sláintecare are huge and wide-ranging. We do not know the progress to date in terms of what has been spent on it. We do not know what a proper costing of implementing Sláintecare looks like because it has not been updated. So then I asked, to be clear, IFAC does not know what has been spent to date or the cost of full implementation. No, we do not really know what will be spent beyond 1 year, and we only have 1 year into the future of what we will spend. And then Dr. Eddie Casey says, yes, and I think that even that information has narrowed. I am not sure if we know next year, which is unfortunate. We do not know some of the most basic things around Sláintecare. Would you like to respond to that from IFAC?
Not really, Deputy, no. Do I have to respond?
Mr. Watt, that's not good enough. That's
So,
simply
look,
not good enough.
IFAC
provide a very important role in this stage in terms of budgetary oversight, and none of us understand what's happening with Sláintecare in terms of money.
I don't think it's a fair, objective characterisation that none of us know what's going on with Sláintecare.
No, not none of us. The group tasked with budgetary oversight, independent budgetary oversight in the state doesn't know.
I'm very happy to talk to Sebastian and the team, and
in a public way?
Whenever he wants to talk, I'm happy to.
Publicly?
Well, I'm very happy to give him the information in any format. I don't think it really matters. But yeah, I'm happy to talk to him if there are any questions. I wasn't aware of the discussion at the Budget Oversight Committee. I wasn't aware of IFAC's comments. I didn't see those. But certainly, I don't accept the characterisation, but that's neither here nor there. I'm very happy to give a briefing on Sláintecare, what we're doing, the costs associated where it's within the budget. It's not clearly identifiable within the budget, clearly the way in which we set out budgets, but obviously there's very significant elements of the budget that are related
Okay,
to
so Mr. Watt, do you know how much it's going to cost to implement Sláintecare in full?
Well, if you just take one aspect of Sláintecare, for example...
No, let's not though. Let's not take one aspect. How much will it cost to implement Sláintecare? But it's the job of a department to forecast what they believe it will cost to implement.
But it's a massive multi-annual programme with many different dimensions. And
it's called economic forecasting. We do it all the time.
It's slightly different to that, but we have there are large blocks of Sláintecare which it's very clear there are spending elements associated with them.
Okay.
And
so what blocks are unknown?
So if I go through the elements of
Please
it.
Please do.
So we have the electives, Derek, which the three elective hospitals will have a Derek can give a broad outline. There's a bill associated with those.
And why do we not know the costs of elective hospitals?
No, we do have at this stage have an outline
Okay.
what we think the cost will be at this stage, but obviously we have to go through the tendering process and we'll have a better idea when we see what the tender prices say.
Okay, but I mean...
We can't anticipate what the market will ultimately price the
Well,
jobs
you
at.
can forecast how much a hospital is going to cost. You absolutely can.
No, we can't.
No,
Sorry.
you absolutely can.
No, we can't, Deputy.
No, you
Sorry.
absolutely can. I'm sorry, that's
can give
ridiculous.
you-
This is my area of expertise not so long
I'm
ago. You
afraid-
absolutely can. Put a
You
price
can't-
on
you-
what a
you-
hospital is going to
you
cost.
can't-
Notwithstanding the failure of this state to do so in the past.
Very happy to talk
You
about
can,
the successes
exactly
and the failures of the
right.
state.
You can
Deputy, whenever
forecast a range. That's not correct to say, Mr. Watt. You can forecast a cost.
We can come up with a range, Deputy, absolutely a range
Yes,
now
thank
of
you.
what we think
Okay.
today.
So we
the
could
cost
have
would
a
be,
range
but
on
I don't know-
electives. So what other
but
sectors?
I don't know what the cost of cement and steel and everything else is going to be in 2
You
or 3
can
years'
forecast
time.
construction inflation.
If you can.
You absolutely
If I could,
can.
I
There
probably
are
wouldn't be sitting here.
thousands of people in this world who
yeah.
are expert in forecasting
They're not
construction
experts. I'm
inflation.
afraid you can. Anyway,
Okay,
I'm
we
not
don't believe in
they're not
experts anymore.
Nobody's
All
an
right,
expert
fair
on the
enough.
future, right? Nobody's an
What
expert on the
other
future.
than electives? What other costs are not known?
So we have then relation to the affordability programme. So we have in terms of universal. So we've the minister has announced the abolition of inpatient charge. I think that's 80 million. We have set out.
That's a known sum then.
Yeah, we have set
Okay.
out in terms of actions in relation to extending GP care up to the median, the costs of that.
Is
So
that, sorry, the GP care, is that an unknown sum? Sorry, I'm way over time.
No, that sum is set out.
That's a known sum, okay.
That's a
We
known
were looking
sum.
for the unknown sum.
It's in the budget, on the various assumptions about what the rates will be. So there's the electives, there's the ECC costs, which we set out. There's the cost then of the consultant contract. We have an idea what that will cost and of the impact.
Okay, we're
on-
looking for the not known costs.
So there are many areas where we can set out in broad terms what the cost will be,
Great, so
what
then
the costs you've incurred.
could this
then
committee get a forecast of what the full implementation of Salt Care will be?
we can give an estimate of it, but you're talking about.
Great, I would absolutely love an estimate. Thank you.
We can come up with an estimate, okay.